Welcome to Roadmap to Residency, Evidence-Based Application. This video is about gastrointestinal pathology. Again, everything that is discussed in this video is in detail discussed in the gastrology modules, so you can go and check those videos. So this patient has most likely a tumor secreting which of the following molecules? So a 46-year-old woman comes to the office with persistent diarrhea, weight loss, and abdominal pain. Her diarrhea started several months ago and she has no fever, melena, or hematochezia. The patient has not traveled outside of the country and has not drunk from any untreated freshwater sources. She has had no recent hospitalization or antibiotic use. Her sister has a history of celiac disease. Upper endoscopy reveals post-Barber duodenal and jejunal ulcers. This patient most likely has a tumor secreting which of the following molecules? Gastrin, glucagon, insulin, serotonin, somatostatin, or vasoactive intestinal polypeptide. So now this here was a case of Zollinger-Ellison syndrome. Now Zollinger-Ellison syndrome means that whenever there is a gastrin secreting tumor or gastrinoma, there is gastrin hypersecretion. You know that gastrin stimulates the parietal cells, which increases the acid secretion. So whenever there is increased gastrin secretion from the gastrinoma, it hyper stimulates the parietal cell. So there's increased production of acid. Now, if there is increased production of acid, then this acid will ultimately go where? Will go towards the duodenum, and then it will get alkalized there or it will get neutralized there. But the duodenum is not able to neutralize a very large amount of acid production. So in gastrinoma, typically there is a very large amount of acid production. So this acid will again go on to damage the duodenum, causing distal duodenal ulcers. So this patient's clinical presentation is highly suggestive of Zollinger-Ellison syndrome, which is caused by gastrin-secreting neuroendocrine tumor that are most commonly located in the small intestinal pancreas. And the gastrin produced by these tumors stimulates the gastric acid production and often resulting in multiple peptic ulcers that can be located beyond the duodenal wall and are often refractory to the therapy. The patients typically experience abdominal pain and acid reflux, and they may also have diarrhea as gastric acid damages intestinal epithelial cells and inactivates the pancreatic enzymes, preventing proper nutrient absorption. The diagnosis of gastrinoma is made by measuring basal and stimulated gastrin levels, and patients with GES will undergo testing to exclude multiple endocrine neoplasia type 1 due to the strong association between these conditions. So that was a brief overview of ulcers. So here we have a 38-year-old woman who comes to the hospital with 4 hours of abdominal pain, nausea, and vomiting. The patient started in the periumbilical. The pain started in the periumbilical area and is now localized to the right lower quadrant. Temperature is 100.9. On examination, the patient has right lower quadrant tenderness with guarding, and appendectomy is performed. And light microscopy of the appendix shows transmural neutrophilic inflammation, consistent with the diagnosis of acute appendicitis. Now, with further microscopic evaluation, it reveals island of cells as shown in the image below. So the lesion is most likely derived from what? Endothelial cells, fibroblast, hematopoietic cells, intestinal epithelial cells, neuroendocrine cells, or smooth muscle cell. Now, this is a well-differentiated neuroendocrine carcinoid tumor. So we can see a uniform tumor cells with round nuclei, salt and pepper chromatin structure, and eosinophilic cytoplasm. So histopathology of the patient's appendix shows a well-differentiated neuroendocrine tumor, that's carcinoid tumor, which are derived from neuroendocrine cells and often arise in the gastrointestinal tract. Microscopically, this can show a variety of architectural patterns, example island, nest, and are composed of uniform tumor cells with round nuclei, salt and pepper chromatin, and eosinophilic cytoplasm. Now, the cytoplasm contains dense core neurosecretory granules seen using electron microscopy with secretory products such as vasoactive molecules and hormones. Now, these are the most common appendiceal tumor and are usually incidentally found at the distal tip of the appendix in patients who have undergone appendectomy for unrelated reasons. So again, we have one more question here. So which of the following inflammatory bowel diseases is most likely affecting the patient? So maybe this question is asking us about the diagnosis. Let's go towards clinical unit. So 32-year-old woman presents to the gastroenterology clinic with complaints of chronic abdominal pain, diarrhea, and bloody stools for the past several months. She reports a history of intermittent symptoms over the past few years, but notes an exacerbation of symptoms in recent months. Physical examination reveals mild tenderness in the left lower quadrant of the abdomen. Lab investigations show elevated inflammatory markers, including C-reactive protein and erythrocyte sedimentation rate. Colonoscopy reveals mucosal ulceration, erythema, and loss of vascular pattern in the rectum and sigmoid colon. Histopathological examination of biopsy specimens confirms the presence of chronic inflammatory infiltrates with creep abscesses and architectural distortion. Now, with these findings, what do you think is the diagnosis? So yeah, the diagnosis is all about ulcerative colitis. You can pause the video and go through the explanation. So a 55-year-old man presents to his primary care physician with complaints of rectal bleeding and changes in bowel habits, including constipation alternating with diarrhea. He has no significant past medical history and no family history of colorectal cancer. Physical examination is unremarkable. Lab investigation shows no abnormalities. Colonoscopy reveals a large ulcerated mass in the sigmoid colon. Biopsy of the lesion shows malignant glands invading through the muscularis propria into pericolonic adipose tissue. Which of the following histopathological features is most consistent with the diagnosis of colorectal cancer in this patient? Desmoplastic stromal reactions, crypt abscesses and crypt distortion, granulomatous inflammation with multinucleated giant cells, pseudopolyps and goblet cell depletion, hyperplastic polyps with serrated architecture. So the correct answer is desmoplastic stromal reaction. So the colorectal cancer is characterized by the malignant transformation of epithelial cells lying in the colon or rectum. Histopathological features of colorectal cancer include invasion of malignant glands through the muscularis propria into adjacent tissues. Desmoplastic stromal reaction characterized by the deposition of dense fibrous tissue around malignant glands, which is a prominent feature of colorectal cancer. This stromal reaction is a result of interactions between cancer cells and stromal cells, including fibroblast and inflammatory cells, and plays a crucial role in tumor growth, invasion, and metastasis. Now, one more question before we finish. So, which of the following pathological changes is most likely characteristic of the cirrhosis in this patient? So, 55-year-old woman presents to her primary care physician with complaints of fatigue, abdominal discomfort, and jaundice. She has a history of chronic hepatitis C infection and alcohol abuse. Physical examination reveals hepatomegaly, ascites, and spider angiomas. Lab investigation shows elevated liver enzymes, hyperbilirubinemia, and prolonged prothrombin time. Imaging studies reveal a nodular liver contour and splenomegaly. Now, the liver biopsy is performed, and histopathological examination reveals extensive fibrous septa surrounding regenerative nodules with hepatocyte loss and inflammatory cell infiltration. Which of the following pathological changes is most likely characteristic of cirrhosis in this patient? Hepatocyte necrosis and apoptosis, steatosis and lipid accumulation, diffuse inflammation and neutrophil infiltration, diseasing fibrosis and regenerative nodules, Kupffer cell hyperplasia and hemocysteine deposition. So the breathing fibrosis and regenerative nodules. Cirrhosis is the latest stage liver disease characterized by diffuse fibrosis, nodular regeneration, and distortion of normal liver architecture. The most characteristic histopathological changes seen in cirrhosis include the presence of breathing fibrosis and regenerative nodules. Breathing fibrosis refers to the formation of fibrous septa that connect adjacent portal triads or central veins, resulting in architectural disruption and disruption of liver parenchyma. Hold on there, hold on. So, which of the following pathological changes is most characteristic of acute pancreatitis in this patient? Promise this is the last question. So, 45-year-old man presents to the emergency department with severe epigastric pain radiating to his back, nausea and vomiting. He reports a history of heavy alcohol consumption and recent binge drinking. Physical examination reveals tenderness in the epigastric region with guarding. Lab investigations show elevated serum levels of pancreatic enzymes, including amylase and lipase. Imaging studies demonstrate diffuse enlargement and edema of the pancreas. A biopsy of the pancreatic tissue is obtained and histopathological examination reveals inflammatory cell infiltration, acinar cell necrosis, and hemorrhage. Which of the following pathological changes is most characteristic of acute pancreatitis in this patient? Fibrous scarring and pseudocyst formation, islet cell hyperplasia and amyloid deposition, acinar cell atrophy and fatty replacement, ductal dilatation and intertotal calculi, inflammatory cell infiltration and acinar cell necrosis. So inflammatory cell infiltration and acinar cell necrosis. So the most characteristic histopathological changes in acute pancreatitis include inflammatory cell infiltration and acinar cell necrosis. Now, inflammatory cell infiltration, primarily involving neutrophils, lymphocytes, and macrophages, is seen within the pancreatic parenchyma and peripancreatic tissues. Acinar cell necrosis occurs due to the release of activated pancreatic enzymes such as trypsin, which leads to autodigestion of pancreatic tissue. Now, these histopathological features are consistent with the acute inflammatory processes seen in acute pancreatitis. Thank you for watching. Keep studying hard. This video was all about orienting you towards the different sort of questions on pathology of the gastrointestinal system that you can encounter. You can go and watch the gastroenterology module of our R2R course, and you can get a very detailed knowledge about different gastrointestinal pathologies, physiology, pharmacology, and anatomy. Thank you for watching.